Okay, very good. Well, good morning, good afternoon, and good evening, depending on where you are. It's a pleasure to be here. I want to thank Dr. Vanderwerf for having me for today. I will be talking about some basic tenets of the radiological diagnosis or radiological approach to leukodystrophies. These are my disclosures. And the objective of this talk is to briefly look at the role of imaging in evaluation of leukodystrophies, but not only leukodystrophies, but their mimics as well, because when a patient presents and has an imaging study, you may not know whether the patient has a leukodystrophy, and there's certainly quite a number of mimics that do not fall into that classic description and definition of leukodystrophies that Dr. Vanderwerf alluded to. We'll start out briefly showing some normal patterns of myelination on MRI. We'll briefly look at a few sample algorithms for pattern recognition and MRI evaluation. We'll touch base on a few examples of potential information that we can get from certain MRI sequences, and finally look at a brief sample of imaging clues that can help with imaging evaluation. Obviously, this 30-minute talk will rather inevitably be incomplete and rather simplistic, but I hope it will provide a basis for the imaging approach. So as Dr. Vanderwerf alluded to, the role of imaging in diagnosis has become sort of central, became central, helped in the classification and still helps in the classification of leukodystrophies, but the role may have changed a little bit over the years with the advances and availability of various levels of genetic testing. Radiology is often an adjunct or may serve as an initial assessment guiding further evaluation. It may help with targeted genetic testing, interpretation of genetic findings and variants of unknown significance with certain disease staging and assessment of change over time. And certainly it still serves occasionally as a primary diagnostic tool. We're all very familiar with the changes that occur in the brain as far as myelination is concerned from the neonatal age up to older ages and through adulthood. We generally start out with, let's say in these T1 and T2 images, with a gradual flip of the signal intensity of the white matter. In this neonate, we have very bright or hyper-intense white matter, and gradually it becomes a darker or hypo-intense, or relatively hypo-intense compared to the cortical gray matter. On T1 weighted images, it's sort of the other way around. We start out with a normal dark white matter and gradually progress into a much more hyper-intense and brighter white matter. Now, the progression of myelination goes through certain recognizable steps, and there are landmarks and for different stages that different parts of the brain from the neonatal period gradually myelinate within a certain tolerance. For example, in a neonate, you might have myelination in small parts of the corticospinal tract, ventrolateral thalamus, dorsal brainstem, and some of the median midbrain nuclei, and gradually that expands. As a general rule of thumb, myelination progresses from the center to the periphery, from back to front, and from inferior to superior. That's a general rule of thumb. And there are actually at least one disorder that this pattern is not followed. And these changes in myelination, just to probably oversimplify it, occurs as a result of changes in water content, which may go down, and maturation and deposition of complex lipids as part of the myelination process. Now, there are different ways to classify leukodystrophies, but a very common and very useful one is to classify them into hypomyelinating disorders and the demyelinating disorders, etc. So on this left-hand side, we have the normal myelinated brain. In a hypomyelinating brain, the T1 may be normal appearing or almost normal appearing, isointense, or maybe even in some areas mildly dark. And you have the T2 hyperintensity as well, which may be mild. Whereas on the demyelinating disorders, you have the T2 hyperintensity, but often the areas of involvement have T1 hypointensity and are dark on T1. And this could be a good starting point in segregating out the different disorders. So in hypomyelination, we mentioned that the T1 is not very dark. It's maybe near normal, isointense, or just very minimally hypointense. The problem is that if you have a very young child, especially an infant, it might be difficult to differentiate true hypomyelination from delayed myelination on a single MRI. And in these cases, having a subsequent MRI done, for example, 6 months later, allows assessment of the progression of myelination and whether you're dealing with true hypomyelination or some temporary phenomena. Now, there are disorders that cause delayed myelination, and we'll sort of get to those as well. So how do we approach the very large array, almost bewildering array of leukodystrophies and leukodystrophy mimics on MRIs? So one convenient way is at a first starting point would be to differentiate hypomyelinating versus demyelinating, as we discussed. And there are many algorithms out there, just showing two algorithms. The one on the left is from Dr. Eichler and colleagues, who will be talking on ALD later today. And the one on the right is an algorithm by Drs. Schiffman and Vanderknaap. And all of these are quite useful. The one on the left sort of has less number of diseases, but the major ones are in there, and the major canonicals are listed in this algorithm. These are very helpful. And the one on the right, obviously much more detailed, maybe even hard to see, but they are certainly quite helpful in trying to differentiate and come up with an idea based on the MRI of what one may be dealing with. So one branch point might be hypomyelinating versus demyelinating, confluent versus multifocal. And then within those, the predominant locations based on the patterns of involvement, whether the peripheral nervous system is involved or not. So these algorithms can certainly be quite helpful. How about different imaging sequences? So one thing that's often used in radiological imaging and MRI is diffusion imaging. We're very familiar with diffusion imaging in the context of arterial ischemic stroke, hypoxic ischemic encephalopathy, maybe purulent collections, and maybe certain types of neoplastic processes. And this diffusion imaging, which is a reflection of the motion of water, changes in many disorders. And at least in the cases of stroke and HIE, we think that this is due to cytotoxic edema, and in many cases, or majority of cases, is an irreversible process. However, there are other disorders that can have, many other disorders that can have changes in diffusion imaging, so-called restricted diffusion or reduced diffusibility. So this is a young patient with a urea cycle disorder, OTC, and you can see the diffusion changes in this pattern, and you see the T2 signal abnormalities as well. This is a patient, a neonate with sulfite oxidase deficiency, and we can see the marked restricted diffusion in these select structures, and later on they became encephalomalacic. So there's a lot of metabolic and some good dystrophies that can certainly have diffusion restriction as well. This is another example of a patient with a mitochondrial complex 1 disorder and UFV1 mutation, and we can see, in addition to the abnormal white matter, we can see the areas of restricted diffusion and essentially necrosis in certain parts of the brain. So diffusion imaging can be seen in many metabolic disorders as well. However, not all restricted diffusion is irreversible, because diffusion restriction is not just caused by cytotoxic edema. There are many other pathophysiologic mechanisms that can result in restricted diffusion, and one of them is so-called intramyelinic edema. The pathologist might call it microvascularization. These are two prototypical examples. The one on the left is maple syrup urine disease. This is a young infant that has the classic imaging appearance of MSUD. And if this is caught early, we can see pretty much complete reversal of the changes that we see on imaging. And this is due to intramyelinic edema or microvascularization, which may be reversible. Not always, but sometimes. This is another patient with infantile spasms and was put on vigabatrin, and we can see the changes as a result of this medication, which is also thought to be due to microvascularization, and once the medication is stopped, it can reverse back to normal. So this is an electron microscope of the vascularization that may be seen. This is an MSUD case. And so intramyelinic edema can be fully reversible, not always. If it's associated with other damage, it may not be fully reversible or may be irreversible. This is an example of the patient with Canavan disease, a patient with large head, very extensive involvement of much of the white matter. And we, in this case, we had restricted diffusion as well. I'm not showing the ABC map, but trust me for that, that there was restricted diffusion. And this is the microvascularization that you might see in Canavan's disease as well. So as opposed to, let's say, ischemic stroke or HIE, that there is a relatively well-defined and short period of diffusion restriction that then pseudonormalizes and then normalizes. These can go on for quite some time in these patients, months, years, and they may go away. Another question that is often asked or often a study that is often requested is MR spectroscopy in patients with white matter disease or suspicion of white matter disease. So this is a normal spectrum. We have the major spectra. This is a clinical spectrum, clinically acquired spectrum. We have the acetyl aspartate, a neuronal marker, choline, so-called cell turnover marker, and this is the general relation that they have and ratios with respect to each other. In many disorders of white matter, or many disorders in general, we might see a spectrum like this, that we have a little bit of decreased NAA and a little bit of increased choline. We may even have a touch of trace lactate. Now, is this helpful? Not so much in arriving at a diagnosis, because what this spectrum tells us, I mean, a little bit of trace lactate may be normal, particularly in an infant. This just tells us, this non-specific spectrum, that there is something wrong with the brain. And frankly, well, we knew that. And unless we are targeting specific things on spectroscopy, we have specific questions. If we get a spectrum like this, it really doesn't help us pinpoint a diagnosis. On the other hand, certain metabolites, if we're looking for or happen to find, for example, in this patient with an apparent leukodystrophy, this patient had a mitochondrial deletion. We see a massive increase in lactate, and that could be a clue for further investigation. Similarly, in this patient with a large head and a diffuse leukodystrophy, on spectroscopy, we can see a massive increase, massively large NAA peak because there's no aspartate, so N-acetyl aspartate accumulates, and we can see this elevated peak in this patient with Canavan disease. You might see something similar in solid disease, though in that case it's not NAA, it's neurominic acid. So looking for specific signs on spectroscopy would be helpful rather than just a blanket approach. There are other metabolites that we may be targeting, such as succinate, some other amino acids. So moving on to hypomyelinating disorders, this is part of the algorithm that Adeline showed, and we have the hypomyelinating disorders. We have demyelinating. There's some disorders that have a predictable slower pace of myelination, and if we can categorize patients into hypomyelinating disorders, we have a smaller category, and then we can use certain features to help us with nailing the diagnosis. Now, pattern recognition, hypomyelination is helpful as well. This is a patient with Pelizaeus-Merzbacher disease, and in this case, in these patients, often we have a diffuse hypomyelinating disorder as a sort of a pattern recognition approach. Sometimes we may have additional clues, and this is a patient with HABC, hypomyelination with atrophy of the basal ganglion cerebellum due to severe TUB4A mutation. We can see the changes in the basal ganglia here, which are quite small. Now they may not, the initial scan may not show a small basal ganglia, but eventually they can have this picture, and here we have the changes in the cerebellum as well. Other clues, for example, calcification or patterns of calcification. This is a patient with sensory impairment, some cachectic dwarfism and photosensitivity. We see the hypomyelination, we see the calcifications, we see the lactate and atrophy. This is a patient with Cockayne syndrome. Now, calcifications, there are quite a few disorders that can have calcifications. This is a sample list here. One of the great mimickers is cytomegalovirus CMV infections, torch infection, and we'll get to that. So this is a patient with Aicardi-Gutierrez syndrome, which we will hear much more in detail about it later. We see extensive calcification. We see the temporal lobe cyst. Now, there's much more to Aicardi-Gutierrez than just calcification and temporal lobe cysts. There's certainly many atypical forms, and depending on how early the patient presents and stage of the disease, it could be a very difficult diagnosis, but certainly calcifications can be a helpful clue, just not always present. This is a patient with RNase T2 deficiency. We see the scattered punctate calcifications in the white matter. We see the cysts in the temporal lobe, although FLAIR might be easier, make it easier to see those abnormalities. So calcifications can be a clue not only in hypomyelinating disorders, but in the demyelinating as well. Now, this is a patient with a congenital CMV. The patient, this is a older patient, and this was the initial investigation. Now, CMV could be the great mimicker of leukodystrophies. Here, the white matter changes. You may or may not have the malformations of cortical development. You may have the temporal lobe cysts and the calcifications. So this is certainly something that is entertained in the differential diagnosis of many patients. So the question that I often get asked is, can we diagnose calcifications on MRI? The answer is yes and no. On T1 and T2, it sort of depends. Depends on how dense the calcification is, how the degree of hydration around the calcium is, and into which molecule the calcium ion is incorporated in. Now, in the last maybe 12, 13, 15 years, there are more sensitive methods of detecting calcification. One of them is susceptibility weighted imaging and its various incarnations and the pseudo SWIs, not all SWIs are actually created equal. We are able often, not always, but most often able to distinguish calcium because it's diamagnetic and iron, which is paramagnetic. So here we have a few dots. They're both black, but if we do look at the unwrapped phase images, one of them is bright, one of them is dark, and that's how you may be able to, in most cases, distinguish calcium from iron deposition. It sort of depends what kind of system and how the system, the MRI system is attuned, and the coordinate systems. If we have so here we have some dark globi pallidi, but depending on whether the coordinate system of the scanner, the phase images may be bright or dark, so you really need to know what kind of system you have to be able to make that determination. Now, pattern recognition is quite helpful. This is the algorithm alluded to by Dr. Vanderver. It's no longer on the Gene Review's website. It's been archived, but it's accessible via the Euro PMC. It's adapted from the article, in part from the article by Dr. Schiffman and Vanderknapp. So depending on location, there are a list of differentials that can help pinpoint or narrow the differential depending on whether it's diffuse, or whether it's periventricular, subcortical, and many other features. So let's look at a few examples. So this is an obvious sort of diagnosis of classic X-linked adrenal leukodystrophy in a young boy. We have the leading edge with the enhancement. However, as mentioned, there are somewhat atypical patterns as well. This is a patient who is a little bit older. Now, same appearance, but in the frontal areas with the leading edge. Now, there's screening for patients with known mutations to look for early changes. So patients may be candidates for a transplant. So in these kinds of screening examinations, looking at the earliest changes, for example, here in the splenium, becomes very important. And by the same token, sometimes they can start anteriorly. It's upon us to very crucially and very in detail look in all areas that may be involved. So this is a patient that the start of the disease is in the genu of the corpus callosum. This is another one that Adeline showed, frontal predominance in Alexander's disease. And this is a younger patient, the so-called type 1 or neonatal or infantile form. We see the caps along the frontal horns. We see the signal abnormalities in the basal ganglia, and we see the areas of enhancement and the changes around the ventricles. Now, depending on when the patients present, you might have sort of non-classical appearances. These are patients with Alexander's disease, but the frontal predominance is essentially not there, but we still do see some of the features, the caps or the comma-shaped periventricular signal abnormalities and a little bit of the basal ganglia abnormality. And this is another patient, older, presenting with Alexander's disease. You can see the very little supratentorial involvement, but we see the brainstem abnormalities, we see the contrast enhancement. This is the dorsal brainstem. As you can imagine, this patient presented with a lot of vomiting, so-called type 2 or juvenile or adult form, although there's overlap between those as well. Now, how about confluent and diffuse? This is an example of a patient with MLC, megalencephalic leukoencephalopathy with subcortical cyst, large head, doing poorly at school, actually functionally doing much better than what you can see on the MRI. You can see the diffuse involvement, and this is a flare sequence that helps with delineation of cystic changes or disruptive changes in the white matter. This is another example of a diffuse involvement with vanishing white matter disease. And again, the flare can help with seeing those changes which may not be as readily evident on T2-weighted imaging. How about multifocal patterns? These are two examples that have these small cystic areas with maybe some prominent perivascular spaces. The one on the left is Lowe syndrome or oculocerebrorenal disease and mutation. You can see these patchy, multifocal areas of white matter signal abnormality with these multiple cystic changes associated with it. This is a patient with P10 mutation. Many of these patients have macrocephaly and autistic features, and we can see these areas of posterior periatrial abnormality with prominence of the perivascular spaces. Now, it's important in these cases to look at it in a more global fashion and consider the clinical features, because sometimes you can't see a little bit of posterior capping normally, or when the occipital lobes are touching each other, you might have signal abnormalities. And having perivascular spaces is not necessarily a sign of this mutation. You can see it in patients with developmental delay or sometimes normal individuals. You can see them in patients with mucopolysaccharidoses as well. This is another pattern of sort of predominantly subcortical predominance and almost relative sparing of the periventricular white matter. This is a current Sayer patient, which we can see these prominent subcortical abnormalities with almost a thyroid pattern, but sort of predominant relative sparing of the periventricular white matter. The one on the right is L2-hydroxyglutaric aciduria, sort of relative sparing of the periventricular white matter. We do have basal ganglia changes and prominent dentate abnormalities as well, though again, dentate involvement. There's a pattern recognition for that as well, whether it's the hilum, it's the whole thing, whether it's the rim, what other associated abnormalities. Now, there's some that are sort of more periventricular and deep with sparing of the subcortical U fibers. This is the classic prototypical one of those, and a common leukodystrophy, metachromatic leukodystrophy, which at least in its early stages, you can see these black or dark spared subcortical U fibers, and that could be a hint. Now, this sort of so-called tigroid pattern, it's not just simple perivenular sparing. There's much more complex pathophysiology to it. And this tigroid pattern is not necessarily specific to metachromatic leukodystrophy either, but this is the prototypical appearance, and there's no contrast enhancement in here. This is a sort of a more complex involvement here, which may have periventricular predominance, but again, depending, as we heard, depending on the age and increased experience, sometimes these rules are broken. This is a patient, 5-year-old with progressive decline, and this is a particular pattern that we can see involvement of the trigeminal course, intraparenchymal course of the trigeminal nerve. We have brainstem involvement with involvement of the lateral corticospinal tracts, the decussation of the lemniscus at the midline. We see involvement of the anterior spinocerebellar tracts, and we have involvement of the spinal cord as well, particularly at the lateral and dorsal tracts, the dorsal columns, and with much increased lactate. This was alluded to. This was a patient with DARS2 mutation, and we'll have a talk on the tRNA, mitochondrial and non-mitochondrial tRNA disorders as well later today. Now, contrast enhancement, should we give it or not? Well, there's certainly some disorders that it can help in questionable cases or better define or increase the confidence. One of them is XALD, which we talked about, Alexander's disease that we talked about. Many of the brainstem lesions can enhance certain areas of the supratentorial compartment, can enhance and can be helpful in further increasing the confidence in these disorders, though many leukodystrophies do not show contrast enhancement. How about other clues? For example, looking at the cranial nerves. Here's a patient with metachromatic leukodystrophy. We see enhancement in the 5th nerve, 7th, and 8th nerve bilaterally, and this is something that is relatively commonly seen in metachromatic leukodystrophy. This is the one on the right is a patient with Krabbe disease with the dense thalami. Again, the thyroid pattern, which we said is not entirely specific, but enlargement and enhancement of the optic nerves is also something that can be seen in Krabbe disease. Now, in these disorders, sometimes you might see enhancement in the spinal nerve roots as well. Occasionally, you may have brain malformations. These are 3 disorders which we have abnormally thin corpus callosum, and these are disorders that may come into the differential diagnosis of leukodystrophies, although they may not be true leukodystrophies in the classic definition. Other brain malformations that sometimes we see along with the white matter changes. This is a patient with Zellweger syndrome or cerebrohepatorenal syndrome. We can see extensive polymicrogyria, malformation of cortical development, see these subependymal cysts. This is pathology showing the polymicrogyria. So sometimes you have these structural abnormalities along with the white matter changes in some leukodystrophies or leukodystrophy mimics. So in summary, these MRI-based algorithms, particularly for the canonical or recognizable the disorders, are quite helpful, separating them out into hypomyelinating, demyelinating, location. However, there are certain additional clues that can be helpful on imaging, diffusion imaging. Occasionally, if we have a targeted spectroscopy, presence or distribution of calcification, cranial nerve or other malformations, contrast, presence of cysts, so on and so forth. So just to conclude, again, this was inevitably an incomplete talk, but imaging is nevertheless an important tool in the evaluation, either as a primary tool or as an adjunct to the clinical laboratory and genetic evaluations. Pattern recognition based, let's say, on hypo and demyelinating categories are helpful. Looking at the additional clues and additional imaging sequences and what they can provide us can be helpful. And it's important to realize that the imaging appearance, it depends on the time of presentation of the patient, time of imaging, the various phenotypes of the same disease. It can be a little bit different from the classical appearance. And the more we learn about these, we find more exceptions to these rules. Thank you very much, and thank you to my colleagues, Drs. Vanderver, Waldman, and Dang. Thank you for your attention.
Fantastic. Thank you for that excellent lecture. So just a reminder, folks have questions, you can place them in the Q&A button. We do have a question that's live right now. When to call hypomyelination in infants that are in the process of myelination?
Yeah, that is certainly challenging. So there is a rather well-described progression of myelination depending on the structures, whether it's the deep white matter, periphery, dorsal limb, posterior limb of the internal capsule, anterior limb of the capsule, splenium, genu. So there is a sort of known progression. However, in infants, it might be, if you just have a single MRI, it might be challenging, or often is challenging, to call it a hypomyelinating disorder rather than just some delayed myelination. Many of these patients catch up, some don't. So that rule of thumb of 6 months might be quite helpful to be able to sort out those patients.
All right, fantastic. There's a second question. Thank you for your excellent talk. You mentioned trigoid pattern is not specific for metachromatic leukodystrophy. What other disorders are in your differential for this pattern?
Yeah, I mean, that is the classic appearance of metachromatic leukodystrophy, and many of them will end up being metachromatic leukodystrophy. But for example, I showed a patient with Krabbe's disease. I showed a patient with Kearns-Sayre, and those also had the thyroid appearance. So I think it's important to, while useful to rely on the thyroid pattern, but not rely on it too much. Look for other features on the MRI and on the clinical presentations to sort of broaden your differential diagnosis if you don't fall into that, oh, if all thyroid is metachromatic leukodystrophy. Actually, I've seen that very frequently, that any thyroid is automatically called any hint of thyroid, even if it's not thyroid, sometimes it's like a leopard, is called metachromatic leukodystrophy, and many of these patients end up not having that disorder.
Okay, we have another question. When you've not yet done imaging and are sedating the patient to do so, and you suspect you may see a leukodystrophy based on clinical history, do you recommend routinely doing a positive negative contrast, spine imaging, and MRS, or would you do a more limited series and then go back to more imaging to clarify?
Yeah, practically speaking, that is very practice environment dependent. There are certainly groups that give contrast to everyone regardless. Now, sometimes if there is a canonical pattern that you think will be enhancing, maybe a good idea to give it. But, just the practical aspects, doing full spine imaging, doing a spectroscopy, giving contrast, do you have that capability? I think if you have the capability, maybe doing one or more than one of them, it's possible, but sometimes there are constraints for the next patients that maybe you can't extend a half an hour scan to a 3.5 hour scan or 3 hour scan. So it depends. So I think here at CHOP, we check every patient that's on the scanner before they come off the table, and we add things as based on what we see. But again, you have to strike the balance, and sort of depends on what you see. So if you can do it and you think it will be helpful, sure, go ahead. But again, practically speaking, there may be some constraint.
Okay, there's several others. I think we'll probably have time for 2 or 3 more, and then any questions that we don't get to, we will flag them and come back to them we have time later on. The question is, do you typically write anything in the comments to radiologists on MRI brain with or without contrast in order to help you decipher between some of these entities?
Sorry, what was the question again?
Do you typically write anything in the comments to radiologists on the MRI brain with or without contrast in order to help you decipher between some of these entities?
Well, I don't. I am the pediatric neuroradiologist, but I think it certainly can be helpful, and it's been shown that having histories increases the chance of a radiological diagnosis or narrowing of the radiological diagnosis tremendously. There have been studies that have shown that. So if you don't write anything and just write rule out disease, you're doing your patients a disservice. So even a one-liner can go a long way. At our hospital, we do have access to the patient's electronic medical record, which is the entire medical record of the patient. So in many cases, we do have the access to that information, even if it's not explicitly given to us. And I think that certainly helps in many aspects in, for example, the question whether to do additional imaging. So much of that depends on the suspicion, not just in leukodystrophies, but for almost anything. So I would say if you can spend that extra 30 seconds to give that one-liner, two-liner, I think that in many cases that can go a long way. Okay. Thank you very much, and thank you for everyone's attention.